Good morning to all. Okay, I'm going to present expect the unexpected. Yet a 34-year-old female from West Bengal came with complaints of swelling of face and limbs for 1 year, and weight loss for 1 year, and loose stools for 8 months. And she also had a history of associated weight loss of over 30 kg in 1 year, and loose stools which was oily and greasy for 8 months, which float over water, not aggravated after any specific food. She also had a history of hyperpigmented itchy macular rash over all 4 limbs for past 7 months without any bleeding manifestation, and a history of hair fall with a wide discoloration of hair for past 4 months, not associated with any scaling. She also had a history of dryness of mouth, no history of any fever, cough, dyspnea, abdomen pain, no history of joint pain, early morning stiffness, skin tightening, photosensitivity, no history of any dysphagia, Raynaud phenomenon. She doesn't have any comorbidities, no significant family history, menstrual history. She was married and had two children, and she had amenorrhea for past 6 months. On examination, she was conscious, oriented, pallor was present, no ictus, clubbing, cyanosis, lymphadenopathy, bilateral pitting pedal edema was present, generalized swollen, puffy face appearance, and hyperpigmented macular rashes over the extremities. Vitals are stable. CVS examination was normal. RS normal, vesicular blood sound heard. Per abdomen was soft, no organomegaly, no free fluid. Bowel sounds are normal. CNS was no focal neurological, and musculoskeletal system examination was normal. This is a syndrome complex of 34-year-old female with weight loss and chronic loose stools and swelling of face and limbs, and hyperpigmented rash, hair fall, and dryness of mouth with amenorrhea, and examination findings showed pallor and bilateral pitting pedal edema. Okay. Differential we considered was a connective tissue disorders, SLE and scleroderma, Sjogren's and mixed connective tissue disorder. For weight loss and chronic diarrhea, we considered a pancreatic insufficiency, celiac disease, inflammatory bowel disease, and Whipple's.
So that you are presenting complaints. That's your history, yeah. So when you have that 30 kg weight loss and oily stool for 8 months, what does it tell you?
Malabsorption.
Malabsorption. What specifically are you looking at? When you get that history, what malabsorption are we looking at?
Pancreatic.
Fat malabsorption. Fantastic. So then, why would somebody get these hyperpigmented rashes and all that? That is later, no?
Yes.
So, would people get that if they've had malabsorption for a long time?
Yes.
Yeah?
Yes.
In your pediatric posting, is there something that you looked at that is very similar in a cert to this? When you're doing MBBS, pediatrics, is there something that is very similar to all these things?
Yes.
You remember that condition?
Nutritional deficiency.
What is it called? It used to have a name when I did my pediatrics. I don't know if it's changed.
Malnutrition syndromes in children, you know.
Marasmus cashew.
So, will you get all these things there? Rash, swelling, edema, right?
Hair discoloration with hair.
Yeah?
Yes.
Because all that you're describing is, so putting that differential, if you were to look at, just go back to your differential. The first differential should be what you think is most likely. Differential, yeah. Yeah. So was there anything to suggest SLE in this patient? Was there photosensitivity, rash? Nothing. Okay. Was there anything like Raynaud's, difficulty swallowing, dry eye, dry mouth? So that whole set of connective tissue disorders shouldn't be the first thing that you think of. That's right. What you're saying second is right. But then that shouldn't be the first thing. But can you have malabsorption with scleroderma? Yes, there are certain situations where, but that's not the first thing they'll present with. Okay?
Okay.
So put what is common first, or what you think is most likely diagnosis first, and then order it in the, what is the likely second, third, fourth diagnosis. Okay?
Our clinical syndrome should be protein bar fat malabsorption in a 30-year-old female. And the differentials should be for that.
Okay.
Everybody is trying to tell you is what clinical diagnosis first. Clinical diagnosis is fat malabsorption. Etiology of that is what you thought of in an order of presentation, like fat malabsorption. So you give a differential for fat malabsorption before you give SLE or scleroderma.
Okay.
From current slide.
Investigations, autoimmune workups are negative, and anti-TTG was negative. Fecal calprotectin was also negative. Stool elastase was less than 18. TSH was normal. Vitamin D was 31.8. ACTH was 24.9. Serum cortisol was 14.2. And HbA1c was 5.5. Total count was 7,100. Neutrophils was 61, lymphocyte 32, and platelet was 2.55 lakh. Creat was normal, electrolytes was normal, and LFT showing albumin was 2, liver enzymes and was slightly elevated, and total and direct bilirubin was normal.
The total protein there?
The protein.
You didn't write the total protein. What is the total protein? Because usually that gives you a clue. If you have a normalish total protein with this, then you think about inflammatory. So it gives you some ideas when you see that total protein with the albumin.
Total protein was low.
Was low?
Yes.
Sure.
How does that help you with?
AG reversal.
So when you are having hypoproteinemia, you would want to know if it's selective or non-selective to see if it's an acute state or a urinary loss. When you're having a non-selective hypoproteinemia, it's most likely a gut loss. It's again favoring your diagnosis. Okay.
Yes.
So
Yes. Yes. Serum electrophoresis showed a decrease in albumin. Urine benchmark protein was negative, and HB was 9.8. Peripheral smear showing a macrocytic normochromic anemia, and iron was 49 with ferritin 243, and total iron binding capacity of 145. B12 and folic acid was 1820. Chulakalbet negative. Gastroscopy and colonoscopy showed normal mucosal study, and our CT abdomen pelvis showed complete fatty replacement of pancreas with no residual pancreatic parenchyma, suggestive of total pancreatic lipomatosis. The final diagnosis we came to is what total pancreatic lipomatosis with exocrine and endocrine deficiency of pancreas with nutritional deficiencies and macrocytic amochromic anemia and secondary amenorrhea.
Come to a scientific forum. How did I come to the conclusion there was deficiency of A, B, E, and K? What are the tests you should be?
Airfall and amenorrhea, vitamin D deficiency
Vitamin D.
will cause.
What was the INR? That's what madam is asking. What was the PT INR of this patient? Did the patient have any eye manifestations in the eye clinically? What was the vitamin D level? That's the question.
So your investigation should be in that order. Investigation is gathered. So you have given us a diagnosis, then you have to tell us each individual part of the diagnosis, how you logically thought and done investigations. And then with that, you give us a final diagnosis. Because none of these match the tests you showed us. And the original.
The investigations are all around. There is no flow to your approach. And the problem there is a lot of unnecessary investigations. That takes away from what we are trying to tell. Okay. And for all residents, for every female patient with low albumin, please don't do a connective tissue disease workup bar a paraproteinemia work. There is no indication for electrophoresis here. Let's not become into the habit of doing this battery of tests for everybody based on their age. That takes away the flow of how we are approaching a problem. And we are stumbling upon diagnosis instead of searching and finding it. These are all diagnoses that you've stumbled upon. Some CT showing something. We have sent a panel of tests and we have got something. Where these are very straightforward algorithmic approach cases. No? It's a clear protein fat malabsorption. Is it gut? Is it pancreas? It's a straightforward approach. I think we've gone very haywire and found something in the end.
Pancreatic lipomatosis is a rare disorder that manifests as a fatty infiltration or total fatty replacement of pancreas. It may be either focal or total. The etiology for this is unclear, but there is a predisposing factors that causes a total pancreatic lipomatosis. That was advanced age and obesity, metabolic syndrome, hereditary or chronic pancreatitis, diabetes mellitus, prolonged steroid therapy, hemochromatosis, pancreatic duct obstruction, Cushing syndrome, and congenital diseases like cystic fibrosis and Schwarzman-Diamond syndrome. The clinical features depend on the extent of fatty replacement. If there is a minor focal fat replacement, the patient is usually asymptomatic, and if there is a vast total fat replacement, patient present with malabsorption symptoms like diarrhea, abdomen pain, and exotic pancreatic insufficiency with weight loss and steatorrhea. The diagnosis is usually made by CT and MRI. Stool elastase was a reliable and non-invasive method to evaluate malabsorption. The management is mainly to improve symptoms of malabsorption and treat dietary deficiencies. Pancreatic enzyme replacement therapy with dietary counseling is the mainstay of treatment, and for insulin therapy for diabetic control. Exocrine pancreatic insufficiency, usually the clinical features will be steatorrhea, abdominal discomfort, bloating and weight loss, and associated malnutrition with a trace element and vitamin deficiencies, with decreased immune competence and muscle spasm and metabolic bone diseases. This is a case report from PubMed about pancreatic lipomatosis. A 60-year-old female presented with chronic diarrhea, weight loss, steatorrhea with diabetes, and pallor was present. CT abdomen showed a complete replacement of pancreatic parenchyma with fat, and a clinical improvement was seen after 8 weeks of pancreatic enzyme replacement therapy. And this is another case report. This is a 19-year-old female presented with complaint of foul-smelling loose stools, difficult to flush, aggravated after eating fatty foods. In normal and lab investigation was normal. CT showed a total homogeneous replacement of pancreas by fat, no calcification or intraparenchymal mass. Total pancreatic lipomatus is also considered in a patient presenting with malabsorption. CT is reliably used to rule out the disease. In our patients, she showed a complete pancreatic lipomatosis leading to pancreatic insufficiency, and she had features of malabsorption. With protein malabsorption, cause reduced albumin, and hypoproteinemia lead to swelling of face and bilateral pedal edema, and sugar levels also elevated, suggesting a endocrine insufficiency also. She also had non-scarring alophasia that is due to nutritional deficiencies. She was started with pancreatic enzyme replacement and a multivitamin, and insulin was started to control blood sugar levels. The learning points will be nutritional deficiency resulting clinical picture may mimic systemic illnesses and further confounding diagnosis. In practice, high index of suspicion is maintained as a different nutritional deficiency can manifest with the overlapping features. Careful evaluation of history, clinical and serological findings by physician help to diagnose and address these conditions.
Thank you. Since this is a image-based diagnosis, it would have been nice for you to show us the CT image of that dark pancreas. Since we are a little low on time, we'll go on to the next presentation, Kripa Medicine 1.